Thank you for coming to Really Little Humans, Basics of Neonatal Resuscitation and Care. So you're in the ED and suddenly you hear somebody yell, "Here it comes." And this is what you say. So you just delivered a baby, cord's clamped, mom's being cared for. What happens now? So there's three big questions that we want to ask ourselves at the time of every birth. Were they born at term? So the biggest difference between your preemies and your micro-preemies is that everything is much more exaggerated in the micro-preemie world. They're at higher risk for hypothermia, hypovolemia, respiratory complications, hypoxia. You can see here, there's a couple of different pictures of what you would expect to see for a micro-preemie, a preemie, and a full term. But this needs to be that first question. Were they born at term? Was this an expected kind of time frame for your delivery? Are they breathing or crying? That's big question number 2. And do they have good tone? So that's your third big question. You can see here, this infant on the left has really poor tone, is very flaccid, and the infant on the right has really good tone, is pulling his arms and legs into his core. All right, so if the answer to all three questions is yes, then the baby can stay with mom, be warmed and dried, orally suctioned as necessary. But if the answer is no to any one of the questions, the infant needs to be brought to the warmer for further assessment and potential resuscitation. And if you're working pre-hospitally, consider calling for an additional crew if you're able to, or set up a space away from mom to be able to do a resuscitation if needed. You want to crank the heat up in that truck to keep the infant wrapped up and warm. So do the best that you can with the resources that you have, which are going to be pretty limited pre-hospitally, but you definitely want to have a little bit of a space to work. You want to make sure it's a nice warm space. All right, so when we talk about warm spaces, the infant warmer. So as soon as you suspect that there's a delivery or you're preparing for a delivery, so let's the EMS calls in saying we're 5 minutes out with the mom that's delivering, we want to go ahead and turn the infant warmer on to begin to warm the surface. The goal is to target a newborn's temperature at least 36.5 degrees Celsius, but not greater than 37.5 degrees. We don't want to cook them. We just want to make sure they're warm, right? So don't forget to put that temp sensor on the infant so you can closely monitor their temp and don't accidentally overheat them, which can happen if you're not closely monitoring. Hypothermia, it increases the risk of neonatal respiratory distress syndrome, hypoglycemia, intraventricular hemorrhage, and late onset. So you really want to make sure that we don't cause or allow hypothermia to happen. And again, if you're working pre-hospitally, look and see if you have any plastic wraps, chemical warmers, warmed saline bags on board that you could use to help maintain the temperature of the infant, both prematurely in the field, but as well as turning the temp up in the truck again and drying the infant and placing them in warm dry blankets. You'll notice that there's other aspects to the infant warmer, and you can see here in this image to the right, other than just warming. So you've got an FiO2 and a medical air plunger, there's suction, there's an APGAR timer. So you really want to make sure you understand how the entire piece of equipment works, even though we kind of refer to it as the infant warmer because that's the primary use that we're typically seeing it for, but it has a lot of other pieces as well. And we're going to talk more about some of those pieces in a little bit. All right, so what are those initial steps? What do you actually do? You get the infant over to the infant warmer, it's on, and then you say, well, now what? So like any other situation, you want to start with the basics. You want to dry, provide warmth, position the head and neck to make sure the airway is nice and open, and if needed, maintain that open airway, and stimulate. The infant that's born full term is breathing well, breathing independently, and has good tone, can be closely monitored and have their APGAR score assessed, and routine care can just go ahead and be given. So you asked those 3 questions, you brought them to the infant warmer to be on the cautious side, but when you look at them, you say, no, they're breathing well, they're moving, they're doing all the good things. So let's figure out what an APGAR score is. So the APGAR score is a scoring system that provides a standardized assessment of infants after their delivery and includes the different criteria that you see here on the screen. So you've got your appearance, your skin color, your heart rate, reflexes, muscle tone, and respirations. Each is given a score of 0, 1, or 2, and the APGAR score quantifies clinical signs of neonatal depression, such as cyanosis or pallor, so that's where the color comes in, bradycardia, depressed reflex response to stimulation, apnea, gasping respiration. So it's identifying the things that you see and you recognize are not right but it's giving you a clinical criteria to be able to work off of. So this score is reported at 1 minute and at 5 minutes after birth for all infants. And if you get a score of anywhere from 7 to 10, that's very reassuring. A score to 4 to 6 is moderately abnormal, and a score of 0 to 3 is extremely abnormal. Now, the thing about the APGAR is, though, it's not done until the 1 minute mark, and it gets repeated again at the 5 minute mark, which it can be helpful in determining if your interventions are improving, but it shouldn't be the only tool that you're using to determine if they need resuscitation. Because if you think about it, if we're waiting around for the first whole minute until we can do this APGAR score, if they're not breathing, we want to be intervening on that a lot faster. So NRP actually put out a statement saying that the APGAR score is useful for conveying information about the newborn's overall status in response to the resuscitation. However, resuscitation must be initiated before the 1 minute score is assigned. Therefore, APGAR score is not used to determine the need for initial resuscitation, what resuscitation steps are necessary, and when to use them. So again, it's an excellent tool to be able to say that we're improving, or if it's in a healthy infant, to say that but it's not something that we're going to wait around until we get a score to determine if we're actually going. So let's say that you delivered a baby that answered no to one of the previous 3 questions. Right? You brought them to the infant warmer to warm, dry, and stimulate, and then you notice that they're not breathing or crying still after that. The APGAR is a full minute away, and you feel like you really need to do something right now because they're not breathing. Where do you actually start? Airway. It's kind of like with anything else, right? Airway, breathing, circulation. So let's start with airway. So the first thing you want to do is position their head to open the airway and clear the airway as needed with suction. You can either use a vacuum suction or a bulb syringe, whatever you have available. Continue to dry and stimulate as you open and position that airway, and it should take no more than 30 seconds to actually do this step. And during that time, you should be assessing the respirations and heart rate. And when you're assessing the heart rate, it's actually ideal to either use a stethoscope or put the infant on the monitor. Common practice used to be to feel at the base of the umbilical cord, feel the pulse, and actually like either tap it out or count it out so that everybody around you could hear. But it can really be difficult sometimes to get an accurate rate from that. So a stethoscope or a monitor are really better choices if you have the option. And if the infant is breathing independently, has a heart rate over 100 after you do that airway maneuver, continue to assess them closely. It seems as if you fixed the problem. Maybe they had a mucus plug that was just in the way, and you got rid of that. Maybe they were just flopped down and they occluded their own airway. And by doing any of these positionings to keep their head nice and neutral, you opened it back up. So heart rate over 100, breathing independently on their own, just continue to closely assess. But if they're not breathing, say they have apnea or they're gasping or their heart rate's below 100, despite having opened that airway, then we immediately want to go to the next step, which is breathing. Something that I have not been doing that well with lately. All right, so breathing. Want to immediately assist the infant's breathing if they're gasping or apneic by the airway, we suctioned out, none of those made any changes, less than 30 seconds, and then we should immediately be moving to positive pressure ventilation if they're still not breathing. Breath should be delivered at a rate of 40 to 60 breaths per minute, which is just less than a breath a second. And that seems really fast because we're kind of used to adult world, right? Where it's, let's go 12 breaths a minute. But in neonates, we're talking 40 to 60. So at VRH, we have a Neopup, which is amazing. We use that for positive pressure ventilation of little ones less than 10 kilos. And it's actually a little bit safer than doing a traditional BVM because you can set the pressure gauges to ensure that you don't hyperinflate the lungs and cause barotrauma. And if you only have access to a neonatal BVM, so the traditional BVM, but it's neonatal size, just make sure that you're only giving enough air to see chest rise, but really be cautious not to overinflate the lungs. You just want to give tiny little squeezes until you start to see some chest rise. So that Neopup, what does that actually look like? So you can see some pictures here. This is the Neopup that we have set up in T2 right next to the infant warmer. It's a T-piece resuscitator designed to deliver controlled, consistent, and precise pressures. It can provide assisted respiratory breaths to neonates and infants. 10 kilos. For anybody above that, and we're looking to use something else. But that's why we have this lid with the infant warmer, because it works well with infants. It is attached to a blender, so respiratory is able to blend oxygen with medical air to give anywhere from 21 to 100%. And the device gives you an ability to set a peak inspiratory pressure, so a PIP, and a positive end expiratory pressure, or PEEP, which helps to protect the baby's lungs. Because if you think about it, if you're actually able to set how much pressure is delivered into the lung and it can ensure that it doesn't overinflate, then you're protecting those lungs. So when you actually go to set up the NeoPuff, it's recommended that you turn the flow meter to 8 to 10 liters per minute and set your blender to about 30%. And the recommendation is to use a pulse ox to help to guide that oxygen concentration, which we're going to talk about in a minute. And when you actually go ahead and get this system set up, the way that you set your pressures is there's a max pressure relief gauge here so that you can set what the max pressure is. And then this white knob here, you actually can turn to set the pressure gauge. So what you would do is you would push the mask against your hand to occlude it, and then you would turn that gauge until you get the number that you want to see here for your PIP right here. And so what'll happen is when you take that thumb and you push it down on the white piece and occlude it, you're going to see this spike up, and that's going to be your PIP. And that's what we want to goal set to about 20. When you take your finger off of that white piece, but you still have the mask itself occluded to your hand, that's going to tell you your PEEP, which we want roughly about 5. And most of the time this is pre-set up. Respiratory assesses this fairly regularly, kind of like with their ventilators. But it is something good to know, and we're actually going to do a little bit of it at Skills Day this year with the ED staff. And if you're out of the ED staff and you're interested, just reach out to me and let me know, and we can do some hands-on practice. All right, so we were talking about pulse ox to help to guide oxygen delivery. So how do you actually know when to increase the FiO2? So this chart here that you see on the left, the targeted pre-ductal SpO2 after birth, is posted by the infant warmer and teach you. And what you'll notice is that the expected and normal ranges for SpO2 is actually a little bit lower in the first few minutes of life. And that's not something that, unless you're working with this patient population, you would necessarily know or think. So it's a really good chart to assess, to be able to say, okay, I just put this little one 30 seconds in on a pulse ox monitor, and I see that they are 70%. That seems terrible, because in the adult world, 70% is terrible. But if I look at this, I say, oh, actually, well, 70% is pretty good, because anywhere from a minute to 2 minutes is 60 to 70%. So I'm actually in an okay normal range. So if you think that the infant you're working with has a low O2, let's say they're cyanotic, they're not improving with the warming, suctioning, stimulation, airway manipulation, all of those things, and you're moving towards positive pressure ventilation, which is great. We're moving forward through the steps. We want to make sure that we put a pulse ox on either the right hand or the right wrist to be able to obtain an SpO2. So we have an idea of what we're working towards and what we're starting with. And we want to put the SpO2 probe on the right hand because the right arm is receiving pre-ductal blood flow, which is the same blood flow that the heart and the brain are receiving, which comes off of the right subclavian artery. Now, if you were to put it on the left hand, it would be getting an SpO2 reading for the blood flow after the ductus arteriosus, which might be mixed with deoxygenated blood coming from the pulmonary artery across the disc. So when you look here in this image, you can see that ductus arteriosus is a connection between your pulmonary artery and your aorta. And so that doesn't actually close immediately after birth. It can take several hours. And so because of that, we really want, we really want to see what our heart and our brain are getting. So that's why we want to get a pre-ductal SpO2. So if you're trying to remember where to put the SpO2, just remember the right hand is the right place. And you can see this adorable little chubby baby here, right hand up. So the right hand is the right place. All right, so let's say you place the probe on the right hand and you find that you have an SpO2 lower than the expected range that you see here on the chart. Then you can consider turning the FiO2 up on your blender. If you're working pre-hospitally, you're probably not going to have a NeoPuff or a blender. So you would just ventilate with a BVM at either 21%, so room air, or 100% FiO2. You don't have much of a better option in that situation. But if you're low and you feel that you need the 100% FiO2, then follow your guidelines for that. All right, so let's say you started to use positive pressure ventilation. You're not seeing an improvement in the heart rate after the first, say, 5 to 10 breaths. So you give a couple and you're expecting, all right, if I'm now giving good breaths and I'm improving that, then I should see an increase in my heart rate, right? Because the decrease in my heart rate is from the hypoxia. So as I improve that, I should actually see an increase in the heart rate. Let's say you're not. You ask another team member to look for the presence of chest movement with each assisted breath. You're listening with the stethoscope for bilateral breath sounds. You don't hear anything. You don't see any chest rise. So now what? Mr. SOPA. So Mr. SOPA is a great mnemonic to help to remember the corrective steps if you're having a difficult time ventilating an infant. And most neonatal compromises due to ventilation difficulties. So this is a really important concept to understand and to be able to work through pretty fluidly. So we'll go through Mr. SOPA. So M, that's for your mask adjustment. All right, could you have the wrong size mask? Could you maybe not get a good seal by yourself? Do you need another person to help you assess? Consider removing the mask and then reapplying to see if you can get a better fit. You got the wrong size, you just really have it in the right place in the initial phase. That's okay. Pull it off, reposition, see if you can get a better ventilation that way. The R is for repositioning the airway. Try to move the infant's head into a neutral or slightly extended position and see if it helps your ability to ventilate. I know we already talked about airway earlier and opening that airway, and then we said didn't show any improvement. But sometimes when you start ventilating, it's really easy for the infant's head to start to kind of tilt forward and forward and forward as you continue with your ventilation process. And so just readjust, you know, it's okay. Everybody moves. And so if you find that their head isn't in that slightly neutral position anymore, then reposition it. So then that way you can actually open that airway back up again and get ventilation going. S is for suction, mouth and nose. Maybe you can't ventilate because there's a big mucus plug there. Get it out of the way and see if you can get the rise. O, open the mouth. So try lifting the jaw forward to see if you can improve ventilation that way. P is for pressure increase. When we talked about the neopuff, it might not be set at a high enough pressure to inflate the lungs. So increasing the peak inspiratory pressure by 5 to 10 centimeters of water. So if we have it set at 20, then we would increase it to 25 or potentially up to 30. Usually I start going in little increments, so I'd start at about 25 to see if you can get chest rise and improving ventilation. The pressure that you're giving isn't enough to actually pop open those lungs. And finally, A, which is our alternative airway. So you made all attempts and adjustments that you can do to try to make manual ventilation work, and it's just not working. So now you need to consider, do you place a supraglottic airway or do you do an intubation to be able to ensure adequate ventilation? So let's pretend you got through Mr. SOPA. You did all of the steps, you did all the interventions, you didn't see any improvement. And so as a group, you guys decide, okay, intubation is necessary to make sure that we can have proper ventilation. All right. The goal is, if we can, now all of this happens extremely quickly, but if you can intubate before starting chest compressions, that's ideal. Because if you remember, all of these kids, most of these kids, the very high percentage of these kids that are in extremis, it's from an oxygen ventilation problem and not a cardiac problem. So delaying intubation for chest compressions isn't actually going to. So it's kind of the reverse that you would think in adults, right? We harp on chest compressions immediately. We want to get those going. We'll worry about the airway. You know, we'll start bagging a little bit as it's very focused. At the beginning, we just want to get right on that chest, right? These kids are the opposite. Because their primary problem tends to be respiratory, that's what we need to fix. And so delaying that for compressions is not going to improve our outcome. So if you do decide to move towards intubation, you can use a table like in this slide. It kind of talks you through the basic ET tube sizes that you could utilize, or you can estimate the tip to lip distance by measuring the nasal tragus length as seen in this photo. And then you can kind of get a feel for how long of an ET tube it is that you're looking for. If you're using a cuff, so we have cuff and cuffed. If you're using a cuffed, consider going a size smaller or leave the balloon uninflated after. Because when you have a uncuffed tube and you pass it, because it doesn't have a balloon, it actually has a little bit of a smaller diameter externally. And so what we're looking for in a cuffed tube, if you place one, is you just want to go down about a half size to make sure that it can actually place through the cords. Then how do you make sure that it's actually in the right place, right? We kind of follow some of the basics that we would do for an adult. We want to watch it pass through the cords if you're the intubator. We want to watch for chest movement after starting to ventilate through the ET tube. That's a big one, right? Listen for breath sounds. All of that's positive that your tube's in the right place. But you can imagine that on a little one, their chest is really small. And so you could accidentally esophageally intubate them and think that you're having chest rise and think that you hear breath sounds, but you're actually hearing it in the stomach, but the anatomy is so tiny and so tight, and it's such a stressful situation that you just can't be sure. And I've seen that happen. And the big indicator for us in that moment was the color was not improving and the heart rate continued to fall. And it can be very easy to get stuck into the, no, I think I saw it go through the cords. No, it should be good. No, I see chest rise. But if you're not seeing what you're expecting to see, you're not seeing the color improve, you're not seeing that heart rate come up, then that alone is going to tell you that there's some type of an issue. But the definitive way, the best way to assess if your ET tube is in the correct spot is confirmation with exhale CO2. So the only way that we can do this pre-hospitally or in a critical access hospital is to use a colorimetric device. And when we do, we'll see it change from purple to gold if CO2 is present. If you are working in a facility that has more neonatal equipment, we're doing neonatal transport. They actually do have inline and tidal CO2 devices that you're able to connect to, but they're significantly smaller than the big ones that we use in adults, obviously. And so the amount of dead space in there, it's really difficult to put adult one on because you're not going to get accurate readings and there's too much dead space to be able to ventilate through. So we would just use the colorimetric device. So as soon as the tube goes through the cords and you're like, I'm in, you want to connect that CO2 detector and then connect the Neopuff on top of it so you can detect the presence or absence of CO2 during that exhalation. And if you don't get CO2, so it doesn't turn gold after several breaths, then consider removing the ET tube, resuming your ventilation, and doing another intubation attempt. If you're having a hard time visualizing the cords as the provider, or if you've had more than one failed attempt and say you don't have a backup provider to be able to kind of like a second look, then consider a supraglottic airway if you have one that's appropriately sized to the infant. And the other thing that I want to point out with ET tubes is you'll notice the picture on the right with the tube securement. So there are tube holders and securement devices that are made for neonates, and they're fantastic. But I find pre-hospitally and sometimes critical access even, whether or not that equipment is easily available. If you're in a really rapid, quick situation, you don't necessarily have the time to be able to go over and pull a device out because you're starting to escalate on some other aspects of their care. Then using the tape method to secure the ET tube can be helpful. One strategy that I think is helpful if you're the airway provider, so let's say that the infant's been intubated and now you're in charge of actually running the Neopuff and ventilating for that infant, so you're standing at the head of the bed, is actually put your finger into the mouth like this to make sure that you hold the ET tube in place. An infant's airway is really short, and so you can actually tilt their head forward and push the ET tube into the right main stem, or you could tilt it all the way back and accidentally intubate them, so the tube could just come right past the level of the cords, just because the anatomy is so small. So you want to make sure that you hold their head nice and still, and that ET tube kind of in this picture, all with one hand, that can help to minimize the risk of that potentially slipping and occurring, especially if you're having to use it in an extreme situation. All right, so let's get back to our scenario. Let's say you did about 30 seconds of a positive pressure ventilation, you reevaluated, you called Mr. Sopa, you found that it wasn't working, even though you did all of the things that you were supposed to do. And that's okay, that happens. Sometimes you go through all the steps and you do everything and it's still just not working. So you guys ended up intubating the infant. Now, in almost all situations at this point, the heart rate is going to start to increase. If it was below 100, it'll start to increase to above 100 with the appropriate ventilation in place. There are some very select situations that might not happen now. So unfortunately, in our theoretical situation that we're in right now, even after the intubation and confirmation of the tube, remember the confirmation, we want to make sure it's working, the infant that we're working with has not shown an improvement in their heart rate. So that means we need to go to the next step. We've done airway, we've done breathing, we've now secured the airway and are on top of the breathing. So we're going to move on to circulation. Okay. So circulation really is just supported by starting chest compressions. Endotracheal intubation, again, strongly recommended if it hasn't already been done. To do either right before you start compressions, or if you are needing to start compressions, that's fine, but making sure you prioritize that airway, because we want to make sure that we can facilitate and coordinate effective chest compressions and ventilations. And again, remembering that airway ventilation problems are usually the highest cause of issues in these little ones is the oxygenation ventilation problem. All right, so at this step, you want to apply your EKG leads if that hasn't already been done yet. Okay, the monitor is the preferred method for assessing heart rate once compressions actually begin. So again, if you haven't attached to then go ahead and attach that. But at this point, it's usually already on. And when you're doing compressions, you want to use the 2-thumb technique that you can see in this photo. All right, just because it's the best and the easiest way to work with your partner. You're going to turn your FiO2 up to 100% as soon as you start doing compression. So maybe you were at that 30%, maybe you're at Romare 21%, maybe you kind of bumped it to like 40, 50. Just go right to 100% when you're doing chest compressions, and you're going to do a 3-to-1 ratio of compressions to ventilation. So with you and your partner, it's going to be 1 and 2 and 3 and breathe, 1 and 2 and 3 and breathe, to make sure that you guys are working in sync. And it's really quick because again, a neonatal's normal heart rate is high and the respiratory rate is high, and we're trying to help to mimic that. So we want to make sure that we're working really closely with our partner to get that done. And we want to do compressions. Once we start compressions, we want to do them for about at least a minute before we start to check the heart rate to see if the heart rate has increased above 60. Now, if it has increased above 60, then continue your ventilations, monitor that heart rate, and see if it continues to climb to above 100. All right, and then continue to do your ventilation support. If it remains below 60 after a minute of really high quality CPR with ventilations, then we want to think of the next step, right? We've done the airway, we've done the breathing, we've done the circulation, we've tried to kind of get it jump started, and it's not really working. So the next thing would be drugs. So when everything else has failed to increase the infant's heart rate above 60, medications are really the last tool in our box. There's really only 2 medications to remember: epinephrine and normal saline. Ideally, they're given IV or IO. Epi can be given endotracheally, but ideally given IV or IO. And IV access is preferred over IO, and that often means placing umbilical line. And anybody that's placed an IO, you can kind of understand when you're actually doing placement of an IO, it is extremely easy to accidentally drill through the bone, especially in a neonate this small. And so what it was always recommended to me by some of the paramedics that I worked with, which was amazing advice, because I had done several transports where, you know, the facility tried to place an IO and accidentally went through to the back of the tibia, which can happen, is actually to put it in by hand rather than using the drill. And anybody really less than probably, I don't know, a year or 2 years old is actually do it by hand. And so you have better control, you have better feel for when you actually get through that marrow than if you're using a drill, which is just really not sensitive enough in that size. But IV is really what we want. And so in a brand new infant, the only way that we're going to get, I don't say the only way, there's some incredible nurses out there that can place some ridiculously small lines, but the easiest way for us to get direct access is to put in an umbilical line. So that would go in through through your umbilical vein. So when you actually place an umbilical line, it is a sterile procedure in a very chaotic situation. It can be really difficult to maintain sterility. So if there's any concern that it's a dirty line, is what it'll be referred to, then it just needs to be removed and replaced as soon as possible. And that information needs to be shared to whatever tertiary care. So I'm just going to do a basic overview of the process just so that you kind of understand the steps if you're in the situation, but it should only be done by somebody that's been trained to place the umbilical line. But the basic process, so you're going to prep the actual catheter, the umbilical line catheter, by attaching a 3-way stopcock to the end and flushing the entire system with saline. And again, this is all done sterilely. The umbilical stump is going to be cleaned with either iodine or hexadine swabs. And then the provider is going to tie the umbilical stump as low as possible with an umbilical tire suture. You can see here, tie it at the base as low as it can go. And then you're going to cut the cord just below the clamp, just below the umbilical clamp that you would apply right after the delivery. I'm going to cut right below it. You want to make sure you leave at least a centimeter of cord. But the idea is that you want a nice fresh surface to work with so you can actually visualize the vein and the arteries. You can see there's the 1 vein, 2 arteries. And then the provider is going to insert the catheter into the vein. And again, there's 1 vein, 2 arteries. So they're going to insert it into that 1 vein. And then they're going to advance that pre-flush catheter into the vein and then gently advance until they get blood turn. So as they're advancing, they're also withdrawing back on the syringe to see if they get blood return. And it usually ends up being about 2 to 4 centimeters per size infant, but obviously with everything smaller, right? So as soon as you start to get that blood flow, then you can stop. But medications should not be given until blood can be aspirated easily from the catheter. You want to make sure that it has good placement. And then you want to secure the catheter in place for continued IV use. So I've seen some articles online where they say that they'll, insert it just for the fluid bolus or just for a dose of epi, and then it immediately gets removed. In a resuscitation, especially one that we would be doing, I think just going ahead and taping the umbilical cord, securing it somehow the best that you can. Sometimes they'll also kind of tighten that umbilical tape at the base just to hold it a little bit better snugly in place internally through an external maneuver to help to make sure that we don't accidentally advance it or remove it. And then just really once it's placed and you know that it's in a good spot because you're getting good blood after it, note where it is, note what the depth is so that you can tell if it's, grossly advanced or come out and been removed. All right, so actually giving the medication. So dose of epi for neonates is 0.01 to 0.03 mg per kg, or 0.1 to 0.3 mL per kg of the 1 to 10,000 concentration. So a little higher than what we would see in normal pediatrics. In PALS, it's just a straight 0.01. But in this one, it can actually range up a little bit higher. And per NRP guidelines, if you were to give epinephrine endotracheally, you could actually give up to 0.5 to 1 ml per kilo if needed. You haven't been able to get any type of umbilical access or an IO or an IV. Now, you can imagine when you're preparing epi, the doses are incredibly small. So let's say the infant we've been working with throughout the scenario is about 3 kilos. All right, that means giving between 0.3 to 0.9 mLs of epinephrine per dose, right? And it's impossible to give that accurately off of the pre-filled epi syringes that we have in the code card, which is why anytime you're drawing up small doses for any pediatric patient, but especially this patient population, you want to utilize the stopcock method to get an accurate dose. It's just the safest, it's best practice. I've seen nurses before try to take a needle and actually just go through the rubber stopper in the glass vial that connects into the carpy jet. But I've also seen the glass on that break and actually, cut their hand, or they have a needle stick because they now have this exposed needle and just things that we don't need. So the stopcock method is really the best way to do this. So what you want to do is you take that pre-filled syringe. We take our code epinephrine 1 in 10,000 syringe. And then we want to take the smallest empty syringe that we can get without. So let's say that we wanted to give 0.3 ml on this kiddo. I'm going to pick the 1 ml syringe. I don't want a 3, or in this picture, it's a 5, because how am I going to actually pull off 0.3 mLs up if I don't know? It's not going to happen. So you want to pick the smallest syringe possible without going over. So that would mean that if I was trying to give 1.2 mLs for whatever size child I had in that situation, then I'd want to bump it up to a 3 ml that I could actually pull over. So again, smallest syringe that you can get without being too small, and grab that 3-way stopcock. All right, so you want to set it up so that you have the stopcock pointed to off facing the male adapter and connect the 1 ml syringe and the epi syringe to the 2 female adapters on the stopcock. So you can see here, that's the male adapter that could theoretically like an IV or something. We're not attaching it to anything. So it's going to be off there, and you've got your pre-filled syringe here and then your empty syringe here. So now you can easily pull the medication into the smaller syringe and accurately measure it. And so you can either pull on the empty syringe or you can push on the filled syringe. So you just want to make sure that you accurately pull the correct amount. And if you want a little bit more detail on this, on the YouTube channel, there's actually a whole video talking just about drawing up pediatric code medication for the So I would definitely suggest you watching that video if this is something that's new for you. But again, it's the safest way to be able to draw up an accurate dose of a medication for these kiddos. And after you give the epi, you want to flush it with 1 ml of normal. Not doing the 10 mLs like we do for adults. right? We have a very little one, so we want to give very little. So I'm giving 0.3 ml of epi followed by 1 ml of saline. All right, because we just want to make sure it gets into there. You always have to have a flush, but you just don't want the flush to be too much. So check the heart rate about a minute after giving epi, longer if you gave it IO, wait about a minute, and we should see the heart rate increase to more than 60. If it doesn't, after the first dose, repeat every 3 to 5 minutes as needed. Remember, you're still doing positive pressure ventilation and compressions and all of that during this period. So you want to continue to repeat the cycle, so the reassessment and readministration of epi until the heart rate is above 60. Now, if you suspect that the infant is hypovolemic, you could consider giving a fluid bolus. Recommended solution is the just regular normal saline at a dose of about 10 mLs per kilo, given over 5 to 10 minutes. All right, so often the easiest and safest way of giving fluids like that to a neonate is just give it through saline flushes, right? So we have our 3 kilo infant example that we've been working with. A 10 ml per kilo bolus is only 30 mLs. So that equals 3 flushes. So say you have somebody there that's able to slowly push one flush over about 3 minutes, and then wait a minute, and then push another flush, and then wait a minute, push another flush. There's your bolus over 10 minutes. You're never going to want to hook up any type of a bag of anything to somebody this size because the risk of infusing is too high. So if you don't want to use the flushes and you wanted to use a 30 ml syringe and pull it off of the bag, fine. Just don't connect a bag to the infant because you can't accurately, with our setup at least, can't accurately give the right amount. Even if you use an IV pump, the risk if you don't set the volume to be infused correctly that you could over infuse is just too high. So I would really just do it manually. Volume expanders, though, in general, should not be routinely given during resuscitation in the absence of a history or indirect evidence of acute blood loss. Giving a large volume load to an infant who already has myocardial function compromise from the hypoxia can actually decrease their cardiac output and further compromise it. Sometimes we can make the problem worse. So unless we have a really, really good reason to want to give a fluid bolus, probably should. Okay, so let's just put it all together, kind of bring a review of the basics. So remember that full neonatal resuscitations don't occur that often in the field or in critical access. Many times there's an identified risk to the infant and the mother, and they can be transported to a tertiary care center with high risk OB before the delivery occurs. So as intimidating and scary as this situation is, realize that it's not a common place to happen, which is why reviewing this information on a regular basis really helps increase your comfort level, because you're not going to get comfortable with this with the amount of kids that we see that need resuscitation. And thankfully, we don't see that many. So you want to just always keep familiar with the information. Now, this chart kind of gives you an idea of the relative frequency in which you can expect to carry out some of those. So at the top in the green, almost always needed, right? We're always going to assess the baby's risk for requiring resuscitation. We're always going to provide warmth. We might not have to position or clear the airway, so that is almost always needed. And we're always going to dry and stimulate, right? And so if they meet all those criteria and they're pink and they're screaming and they're happy and they're pulling at mom, then that's fantastic. Just enjoy in that moment with parents. Needed less frequently are the yellow sections. So supplemental oxygen, assisting with ventilations, and intubation. Those things are seen a little less frequently. And then very rarely needed by newborns are the compressions and the medication. It's just not something unless they have a really significant congenital problem or something else that's underlying that is just unknown to us. We typically don't see that. So being really confident and comfortable through the airway and the breathing, and then understanding and being able to do the circulation and the drugs is important, but it's something that you're probably not going to see very often. This is the NRP algorithm. It's posted in T2 by the Informer as well. Helps to remind you how to navigate through the airway breathing circulation drugs. NRP courses are fantastic. So you get hands-on practice, you get to talk to people that actually do this on a regular basis, which is amazing because the knowledge that they can give you and the examples and scenarios. So I highly encourage anybody that's watching this to take the course if you're able. I am working with DH to try to see if I can get them to come down and do a course at VRH with us, or potentially even maybe two, because there's a lot of people that are interested. So that is in the works. But if you have the opportunity in any other way, I would definitely recommend it. It's a fantastic course. All right, so just kind of to go over a summary. Caring for these little ones requires you to closely follow the ABCs. You want to make sure the airway is open, make sure there's breathing, whether it's spontaneous or assisted, and be certain that there's adequate circulation of oxygenated blood. Now, although the AHA changed the algorithm to CAB instead of ABC for adult patients and prioritizing compressions over airway ventilation, in neonatal and pediatric resuscitation, the primary cause behind a patient being in extremis is almost always a breathing problem. So the resuscitation should focus first on establishment of an airway and providing ventilation as needed. So we are always going to stick with ABC in neonatal and pediatric care. Medications are further down the NRP algorithm, as airway, breathing, circulation maneuvers are often successful in reversing the problem. All right, if you guys have any questions, please reach out to me. Just remember, if you encounter a little one, if there's a delivery with us, if there's a delivery pre-hospitally, take a deep breath, realize you have all the tools that you need to be able to care for this little one. It's a pretty straightforward algorithm, so just make sure that you review it frequently enough that the information feels comfortable to you, and you're able to kind of walk through what you need to do. You know, what are my steps in Mr. SOPA? What do I do after I started positive pressure ventilation and I'm not seeing an improvement? You know, kind of quiz yourself on those what if scenarios to build up a little bit more of that confidence, and you're going to do a great job. Lots of resources out there, lots of resources just in T2 if you need them. So again, please reach out to me with any other questions, and thank you for watching.